Hello everyone, my name is Nate Campbell and I'm a PGY2 infectious diseases pharmacy resident with mHealth Fairview at the University of Minnesota Medical Center. And I'll be talking about my project for the year, which was the alignment of Piperacillin and Tazobactam dosing across a large multi-center health system. So just a little bit of background. mHealth Fairview is a health system comprised of 10 different acute care hospitals. Some of our hospitals only use extended infusion dosing approaches for Piperacillin and Tazobactam, while others use intermittent infusion exclusively. Piperacillin and Tazobactam is a commonly used empiric antibiotic due to its wide range of activity with gram-positive, gram-negative, and anaerobic activity. Its goal, pharmacokinetic, pharmacodynamic parameter, is a fraction of time above a certain minimum inhibitory concentration. And depending on the organism growing and the organism's minimum inhibitory concentration, extended infusion dosing strategies may be required to meet that desired fraction of time above MIC. That is particularly true for the use of Piperacillin and Tazobactam in Enterobacterales infections. With the 2022 CLSI updates, interpretive categories and MIC breakpoints changed. All the MIC breakpoints shifted down, with more resistance being seen in Enterobacterales with the use of Piperacillin and Tazobactam. And intermediate was changed to susceptible dose-dependent, dose being dependent on using an extended infusion approach. So currently, a handful of our sites aren't using extended infusion dosing, so they need implementation of extended infusion in order to meet that. And our sites that were using extended infusion weren't using strategies that would optimally meet this susceptible dose-dependent category. So some changes were clearly needed for our institution. Additionally, there were some safety events that had occurred over the years with patients transferring from one site to another on extended going to intermittent or intermittent going to extended. Just the confusion of having multiple different dosing regimens had been noted to have led to some errors. So we identified a need to standardize in order to adjust to these breakpoint changes as well as improve our safety culture. So the objectives of the program were to implement a Piperacillin and Tazobactam order set to standardize dosing across a large health system, and then evaluate adherence to the order set and its impact on safety events with a pre-post implementation analysis. The primary endpoint was going to be adherence to the order set, and the secondary endpoints were going to be looking at safety events with Piperacillin and Tazobactam before and after. So the methods would be, this would be a multi-center retrospective study on all patients with susceptible dose-dependent Enterobacterales infections being retrospectively analyzed from January 1st of 2022 till the end of May this year. The data analysis will consist of chart review to determine adherence rates to Piperacillin and Tazobactam order panel, as well as the rates of safety events reported pre and post implementation. Patients need to be greater than 18 years of age with an Enterobacterales infection and susceptible dose-dependent susceptibility to be included. And obviously we'll exclude any patients not on Piperacillin and Tazobactam or any patients that opted out of research. So just looking at our pre-implementation data from January 1st, 2022 till the end of 2023, of our just under 24,000 patients with Enterobacterales infections, only 388 of them, or 1.63% of them, actually had the MIC of 16, which is our susceptible dose dependence. And then looking at our medication errors in the year 2023, of the 4,000, just under 4,000 errors, 158 of them were due to Piperacillin and Tazobactam, accounting for roughly 4% of all of our medication errors. So clearly there's something we could do to improve our Piperacillin and Tazobactam use to avoid all these medication errors. So in order to address that, we've created an order panel that will soon be going live in Epic. Providers will have to select the indication they're treating the patient for. So if it's sepsis, HAP, VAP, or pseudomonal infection, the patient will receive 4.5 grams Q6 over 30 minutes. All other indications will get the 3.375 Q6 over 30 minutes. And then our susceptible dose-dependent Enterobacterales will get a 4.5 gram over 3 hours every 6 hours. Patients will be required to be loaded if this is a new start regimen or they were previously on a regimen that was less than 4.5 grams per dose. And if they were previously already in our sepsis, hep, vax, pseudomonal infection category, and they're already on 4.5 grams, they can go right into their next dose being over that extended interval. Here you can see the renal dosing adjustments we're making for each category. And then additionally, in addition to the order panel, there will be a pharmacist BPA created. So whenever an organism with a susceptible dose dependence is identified, an Enterobacterialis with susceptible dose dependence for zosyn is identified, the pharmacist gets alerted so they can change the regimen to this extended infusion approach if needed. So the next steps will be implementation of the order set system-wide in our electronic health record. This is expected to go live in our April update. Currently, we're in the process of providing education on the order set to all of our providers, pharmacists, and nursing, just to make sure they're aware of the change that's coming. And then we will be doing a post-implementation analysis of the data for adherence as well as analysis of safety events. Some questions I'm hoping to address with this analysis will be, what was the adherence? Did we actually decrease safety events with this change? Potential areas to look at will be what outcomes will look like on patients that are getting this extended infusion approach compared to patients that weren't prior to the change. And then how often Piperacillin Tazobactam is actually being selected when we have one of these susceptible dose-dependent Enterobacterialis. So potential clinical impacts of this are the use of a standardized process for dosing could reduce errors associated with the use of different dosing strategies. The use of an extended infusion dosing strategy for susceptible dose-dependent Enterobacterialis may possibly result in better outcomes compared to patients in the pre-implementation order set that weren't getting extended infusion. And then describing successful implementation of a new order set along with a pharmacist alert in the EHR for when to make dose adjustments for susceptible dose dependence could assist other health systems in implementing similar processes. So thank you for listening to me talk about my project, and I hope you have a good day.